Quick comments, Carolyn. I was very pleased that you touched on diabetes and cholesterol as a side effect of androgen deprivation therapy, but we mustn't forget that the large majority of patients that we see in the office with erectile dysfunction don't have prostate cancer. They have erectile dysfunction because of problems with high blood pressure, diabetes, history of smoking, high cholesterol. So these are risk factors for every man. So yes, we want to focus on what we can do for men on hormone therapy, but if you have high blood pressure, high cholesterol, diabetes, you are compromising your sexual function, whether you have prostate cancer or not. So we must address risk factors. The other thing to say is you're talking about hormone therapy and the side effects, but you're inheriting many patients who've already had the insult of surgery and or radiation, which we know affects sexual function. So often hormone therapy is the sort of final straw, if you will. We'll talk about this more in the panel. In the interest of time, we're going to move on. I'd like to introduce Dr. Melissa Kaufman, who's joining us from Vanderbilt University Medical Center today. And carrying on the same theme, we're going to be talking about sexual rehabilitation after prostate cancer.
That's what we've been waiting for, isn't it? Right? So I do male and female reconstructive urology, which puts me in a little bit of a special situation when we talk about cancer survivorship and some of the events that occur around erectile restoration and all the other type of urologic complications. And that's primarily what I've been tasked to discuss with you today is erectile restoration. But I tell you, these are the conversations that you have to have one-on-one with a patient. Now, I'm often in my clinic, I'm a visual learner. I'm not a very good auditory learner at all. We all assimilate information in different ways. I'm a visual learner. And so I have a lot of diagrams, and when I go and I give talks like this, I've got a lot of slides, and so this is a little bit of an uncomfortable situation with me. You're going to have to bear with me. I did find one thing out in the lobby, though, that I can kind of use for part of the talk. Actually, when we talk about survivorship, that's a remarkable thing, right? Thanks to my oncology colleagues, we get to have this discussion. That you come into my clinic and you're ready to start to live and regain function in your life. And so it gets a little bit irritating when I hear, well, Melissa, you do benign urology. There is nothing benign about these quality of life issues. They have tremendous, tremendous impact. And I think that we need to appreciate that and we need to talk about it up front. And so the way I was told by Daryl that you're probably a little more sophisticated audience than what I'm accustomed to having in Nashville. Has anybody been to Nashville? Yeah, okay. You get it, right? But the way that I've kind of structured this conversation is the types of conversations that I have with my patients in the clinic. Like, what are the questions that they're coming to ask me about? We're not going to go through the entire litany of the erectile dysfunction guidelines from the AUA, although they exist and you can all get them online. But the first thing that I want to tell you about is you have to engage the right person to have this conversation with. This is really an intimate discussion. You have to find a provider that resonates with you because this is going to be a process. It's not going to be a one and done that you have a condition and we're going to work through it in a quick surgery. This is part of your life moving forward. And so if you can engage the appropriate provider who has not just clinical knowledge, but has the compassion and that you can speak with openly, that's the most important aspect about your sexual recovery. So some of the things, I want to go through a list of questions that I find my patients ask me, and maybe you will have asked them too. So the first question is, what should I know about my erectile function before my treatment for prostate cancer? And for everyone that was here earlier and heard Deborah Jennings speak, the things that she wished she knew and that Dale wished he knew, first, it's that you have to know that this is going to have an impact. Right? There's nothing that we are going to do to treat prostate cancer currently that is a friend to your erectile function. So everything is predicated on where we start today. And that means that what we do now means we have to have asked the question before we start, right? And so these are important things for you to have that discussion with your provider about before anything even begins. There was a lot of vogue for many years about a concept of prehabilitation or rehabilitation, of utilizing medical therapies in order to preserve function. And the data hasn't been really robust to support that, and it may be costly, and there may be side effect profiles to it. But the fact is that it engages you in doing something proactive to help. And I think that opens a conversation, and it opens a dialogue with your provider that can be very powerful. But it keeps you in track on how you want to progress through the process. So question 2, why do I have these issues? My surgeon said that I got a nerve sparing procedure. Right? Said they spared the nerves, so why did this happen to me? Right? Some of it may be that it's just poor luck, right? Some of it, though, is that the fact is there's many, many different factors. When we talk, people say all the time, oh, women, you're complicated. No, let me tell you what's complicated. Erections. Men are complicated. So this requires an intact neurovascular pathway that runs from the deep brain all the way through all the peripheral nerves, including the cavernosal nerves that serve the blood supply to the penis. It requires nitric oxide, everybody's favorite, trendy molecule. It requires, well, that's true. It requires that there's many other factors at play. We just heard about the impact of things like diabetes, the impact of hypertension, the impact of all these other things. And guess what else has happened during that time? Well, it's called aging, right? And that impacts everyone. It's interesting. There's a lot of anatomic proximity, but some of the other factors that probably end up causing post-prostatectomy, post-radiation therapy, erectile issues have nothing to do with that local nerve supply and local blood supply. So many other factors are predicated on this, and we can't just assign it to the scissors going in the wrong place during your operation. The other aspect that's kind of interesting is orgasmic function, and this was just briefly touched on. But orgasmic function actually goes through a completely separate pathway than erectile function. Now, men combine these, during your entire sexual experience, but the fact is that you can have orgasm, most likely not with ejaculate, but you can have orgasm without erections. Now, it depends on what your, conversation is going to be with your sexual preferences, but it's always a possibility. The third question is, well, I've made this decision, now where do we begin? And I think that the things we begin with, of course, are these lifestyle modifications. That's going to be our baseline no matter what, ensuring that we have done everything we can to preserve, because you're alive now, you survived prostate cancer, or even if you're in the midst of active treatment, we are looking forward, we're looking towards the next step. So we want to do everything we can to accelerate that and create a system of health, and that includes diet, exercise, control of hypertension, and diabetes. So that's number one. And then number two can be anything you choose. We have a whole suite. Most people walk through least invasive to more invasive, but that's not right for everybody. There'll be men who want to move forward to more advanced therapies early on. And once you've had a good shared decision-making process and an informed discussion, that's fine. That's completely appropriate. So it's all going to be the conversation of what your expectations are, and then what we can bring to the table to make that happen. So you should be very, very clear with your treating urologist exactly what your goals are and how quickly you want them to occur. So when we give you a treatment that may have a time course, be very defined. How long are we going to go through this before we move to the next step? Most men start their erectile recovery with medications. Now, I know that I've got some gray hairs under here. My hairdresser won't let you see them, but I've got them. But I see a few others in the room. Who remembers the world before there was Viagra? Right? Okay. And who remembers what people used to think about erectile dysfunction before Viagra? Right? Before we understood as a community what it meant to have a physiologic metabolic process that ended up with difficulties with erection. So frankly, these medications have changed our entire conversation about men's erections from a social perspective, and that has been just dramatically wonderful for us in urology to be able to help. And most men will start their journey with medical therapy, with pharmaceutical therapy. And so the question I get is, well, I tried it and it didn't work. Right? Okay, well, why don't we talk a little bit more about that? Because it's all about how you utilize those medications. How often, what dosages, what were you doing around that time? Did you have high-fat meals? Did you have alcohol associated with it? So many other factors go into play, and oftentimes it's just a matter of education and re-education for you to be able to successfully utilize a therapy that's as minimally invasive. What kind of side effect profiles do you have from it? Is that going to stop utilization in the future? So paying very close attention to how you're supposed to utilize medications can often end up with very good outcomes in the end. And then for men who move to things like injection therapy, and I've heard that most men in this audience have very sophisticated knowledge of injection therapy. My patient population may not be quite that, but they come back to me and say, well, you did it in the office, you trialed in the office, everything was great. And as a matter of fact, I had one couple who said, yeah, Dr. Kaufman, that injection, it cost me $120. I'm like, what? I said, well, we do it at a compounding pharmacy. They're expensive. Insurance doesn't pay for it, but it shouldn't be $120. She's like, yeah, it was the hotel we had to stop in on the way home from your clinic. That was the problem. I was like, well, okay, that's good. But we got home, and then it never worked again. I couldn't get it to work again. So it's very, this is one of the aspects to utilizing injection therapy. Come back and let's go through the process again. Let's try to figure out a way that if we know the medication is going to work for you and you think that this is going to be a good option, that of course means that you're not ever going to be anywhere without refrigerator or freezer, or that you don't have a lot of pain that's going to require we modify your therapy. But if it's going to be a good option, then oftentimes just further instruction and counseling can take you a long way with these. And we want to be very, very careful about prolonged erections with any of these medical therapies, because if they happen, it's not that we can't treat them, but if they go on for too long, there can be some very severe complications, including permanent dysfunction. But the worst part is that you show up in the emergency room and my intern is down there doing things to your penis that you don't want. Right? So the next question is, well, even when the injections worked, doctor, my penis, no one told me that my penis was going to be smaller. It was shorter, thinner, less girth. What happened to my length? And how do we get it back, right? So there's a lot of plausible explanations for what can happen to penile length following treatments for prostate cancer. And one of them that we just heard about, right, nocturnal erections. So this is Mother Nature's way of continuing to cycle these tissues and stretch them out every night. And when we don't have that, it's potential that there can be scarring and fibrosis in those stretchy erectile bodies. It turns out that when we look at the data across the board, there's not a very good, robust set of information that supports this. Most of it is very modest. So some of the things that we have to understand is setting those expectations of where we were to start with, the other things that have happened, what we perceive as normal for you, and what we are going to be able to regain. So that is a very delicate conversation that has to be done one-on-one, where we open up those doors and actually look and determine this is what we have and this is what we're going to be able to achieve. But you have to set some very realistic expectations around that, because this is one place. I know we spoke about Dr. Google earlier in the day, right? This is one place where Dr. Google does some very, very predatory things. And I can't say that strongly enough, that there are many opportunities out there for mayhem, not just on your wallet, but also on your psyche and on your sexual health. Because promises that are made to you on a website about expectations that seem too good to be true are too good to be true. It's just that simple. Because trust me, I adore my patients. And if I had something that was that magical that could help them, don't you think I'd be using it? Don't you think I would? Like, I took a Hippocratic oath to do the right thing, right? So you want to think about that very carefully. It doesn't mean you can't bring it up to me, because I'm going to give you my opinion, and it's my opinion, and that's why you came to see me. But certainly be very, very careful of those types of predatory behaviors. The next question is, well, okay, we've gone this route. Is it time for me to get an implant? The time for you to get an implant is when you feel it's the time for you to get an implant. And that's any time that you want it. As long as you've had a thorough discussion, the risks and benefits of doing this types of invasive surgery, then it's time. It's time to move forward. There's no, aside from artificial urinary sphincters, there's no more gratified patient population that comes back and says, I wish I'd done this earlier. I wish I'd known that I could have this level of spontaneity and rigidity and sustain a lot earlier, because I've lost 8 years of my sexual health and my sexual life worrying about something that we could have treated more aggressively, yes, but more definitively a lot earlier. Question 8. What about all these other therapies that I read about on the internet? Shockwave, stem cells, platelet-rich plasma. Now, I don't really know what the dark web is, but I know it's out there, right? And you can get all these things probably today, probably right around the corner here in New York City, for whatever you want to pay for them. The Sexual Medicine Society in North America just wants you to know they're all experimental. And outside of clinical trials, the best thing that can happen is that, again, you take a big toll on your wallet and that it doesn't work. The worst thing that can happen is that it's dangerous, because they're unproven therapies and, again, predatory behaviors if you're not done in an appropriate clinical trial. And then the last question is, well, I'm moving forward with surgical therapy, or I'm trying to get some of these other things taken care of. Well, what do I tell people? Like, what do I tell people on my job? What do I tell my colleagues or my friends that is happening? And, I tell my patients, well, you tell them that I've had a complication from my cancer that I need to get taken care of. Nobody asks another question. They don't ask another question of him, never. So I encourage you, for those of you who have partners, to bring them along for these kind of conversations, because it can be very illuminating. They're the ones earlier, like Deborah, that took notes and remembered what was actually being said in these conversations. But we can also help. It's a bonding experience to go through some of the process of erectile restoration together and really help a couple recapture that level of intimacy in their relationship. So I look forward to your questions. Thank you for having me here.
In the last 10 days, Elton John and Rod Stewart have both spoken about their side effects of prostate cancer surgery. So if there was a magic bullet out there to improve sexual function, I don't think either of them would have been writing about it in their memoirs. I'm just going to introduce the last speaker of the session. This is Rachel Hoffman. She has a private practice down in Chelsea. She's a licensed clinical social worker, and she's written publications in the top 3 cited urology journals. That's Playboy, Insider, and Cosmo. Bustle I'm not familiar with, but she'll probably educate us on that as well. So welcome, Rachel.
I've never had an introduction like that before. That was great. So thank you for having me. I am a couples and sex therapist here in New York. I'm also finishing up my PhD. I actually am presenting my dissertation next week, so fingers crossed. Yeah, very excited. So when I decided to become a couples and sex therapist, I have to say the first thought that did not pop into my mind is cancer. And it's interesting because my father being an oncologist, you would think I would have connected the dots. And he specializes in breast and ovarian cancer. So I should have really connected the dots, but I didn't. And it was also through my training that I brought up to him the connection between, cancer and sexuality. And he said, never thought of that before. He's a great practitioner, but now he starts to ask all his clients and patients about how cancer affects sexuality. So I think it just shows that within the medical world, it really needs to be addressed. The most important thing I've learned from my clients in particular is that 100% of people who are diagnosed with prostate cancer are affected with sex, sexuality, intimacy, 100%. And I'll tell you why, because of all the things we heard about today, right? Fatigue, body image, intimacy, anxiety, depression, whatever it is that your experience is, you're affected. And so that was something that I heard from my clients and that I learned that it was extremely prevalent. The emotional impact is something that I really want to get into. And I promise we'll talk about the sexual stuff, but you can't talk about the sexual without talking about the emotional. Because when clients come in with their partners, what I hear, right, is I'm angry, I'm frustrated, I've been through all these treatments, maybe something hasn't worked. I hear that side of the story, and then I hear the partner side of the story. And you have to recognize that there's the narrative of the patient, and then there's the narrative of the partner. And you have to listen and empathize with both sides of things. Because what a partner tells me is my partner has not given me any attention, I feel unattractive, I feel not wanted, I feel disconnected. And so that's the narrative I'm hearing from the partner when the patient is coming in and just stating, I'm super angry, I'm really frustrated, I can't get an erection, I can't orgasm. And so again, it's about hearing both sides of the story. Sometimes what I even do is after I see the couple together, I split them up, and then I have a session with each of them separately, and then you hear a whole slew of other things that come out of their mouths. So the first question I also ask is, what do you want? What is your goal from therapy here? Some focus on the behavioral, right? Like, I want an erection, or I want to be able to orgasm, or I want to be able to ejaculate. And others focus more on the intimacy part. Like, I want to feel close to my partner, I want to feel pleasure with my partner, I want to feel connected to my partner. So you really have to listen and hear exactly what they're asking for, because what I imagined it to be can be dramatically different from what they're coming in with. So the first thing I do with my couples is we do a series of communication exercises, again, because the narrative is so completely different than what you think your partner is going to say. So I'm going to go through a few of the different questions that I ask. Describe a time since your diagnosis when you were able to be intimate in any capacity with one another. Now, why is that so important? Because the definition of intimacy is so widespread, right? And I could break it down into, there's emotional intimacy, intellectual intimacy, physical intimacy, recreational intimacy. So there's a large categories of what it means to be intimate with a partner. So I just want to get a sense of where we're at in all those categories. And you ask one partner, and then you ask the other, and then that gets into a whole slew of conversation in itself. Since the diagnosis, how have your gender roles or marital roles changed? It's in this question that you hear a lot about perhaps like a caregiving role or feeling like, again, I felt like I took over all the responsibilities of the house. Like you'll hear a bunch of different change in roles and responsibilities. And again, there's this sense of, I never knew this, you didn't tell me this. And the reason we didn't tell you this is there's something called the kindness quiet or the fearful silence. So what that means is that both partners are trying to protect each other. And what do? They don't speak. Because I don't want to, say the wrong thing. I don't know if I should bring this up or not. I don't want to hurt you more. So instead, I'm just going to retreat back and not say anything. And therefore, you'll never know how I feel, and you'll never know what I was thinking. And this is how the intimacy spiral starts to decline. I'll also ask, as you're looking at your partner, tell me one thing you find attractive about him or her. The other thing I'll do is I'll send you home with some questions to do, because sometimes what I hear in my practice is, when we're sitting here, we're talking, but then we go home and we're not talking anymore. We don't talk about these types of things at home. So I'll send you home with a list of questions to talk about or ask each other at home, and then you'll come in and we'll talk about how that experience went. And there's a range of questions from more intimate to least intimate, so kind of we go through a range of things together. I hear things about shame, guilt. Again, we talked about feeling anger, frustration, annoyance, a slew of emotions, but also there's care, feeling vulnerable, feeling like I worry all the time, I'm scared, I worry about losing you, all those types of things you hear. And again, these are things that you would assume partners have talked about already, but it just comes out in the office, sometimes very emotionally, which is understandable. We also get into a range of questions about what it feels like to be manly. Based on everything we had discussed prior, a lot of times I hear in my office, my erection is my manlyhood, and my erection is me telling myself I want to have sex with my partner. My erection is the cue to me that I'm aroused, all those types of things. So without it, who am I if I can't get an erection? So when we start into those conversations, again, these are conversations that your partner might not know, or they might know in theory, but you being able to share it again in a vulnerable way in the practice is extremely effective. And the reason, again, I started with the emotional is because until you can connect on that level, I don't want to throw you into a sexual exercise at home. You might not be ready to try it at home. So until both partners are ready, I'm not going to start you on the physical exercises. And I'm going to get into the physical exercises, but once I start those, you're still coming in and we're still talking about the emotional side of things. I don't just stop at the emotional once we start with the physical. So I'm going to go into the sexual side, which I know we're all excited about. And so I say the sexual things, a lot of this is experimenting, right? So if something doesn't work, don't worry, we'll try something else. And there's all these, and again, I'm also working closely with your medical provider, also a pelvic physical therapist. So I'm not just saying to you, you're going to do this and you're going to feel amazing, but it's going to help you, I promise, to at least feel close to your partner and intimate and sexual. And the key, again, is an erection or to be able to orgasm, obviously, but it's a step-by-step process. So what we're gonna do, because I was really told to leave you here with tools, it was driven in, don't leave them without any tools. So I'm gonna take you through a brief sensate exercise. Now, I have to say, you're not at home, you're not in your bed, you're not naked, you're not next to your partner. This is not the most intimate of settings, but we're gonna do our best. And Sensate therapy, which is exactly what I'm going to take you through, is a series of behavioral exercises, and it helps individuals and couples, this is the definition, by the way, get reacquainted with their bodies by remapping their bodies for pleasure. The goal of sensate therapy is to reawaken one's sensual and sexual feelings, and it's a balance of mindfulness and self-exploration. So think about it, when you're getting to know your body in a whole new way when you're younger, we're really starting from scratch right now, getting to know your body, but also getting to know your partner's body. Because like we said before, the aging process, your bodies are gonna change anyway. So why not start from scratch, both partners, and getting to know each other and what's arousal, where are the erogenous zones, it's gonna be fun, right? Okay, so I'm going to have you just trust me on this for a second. Close your eyes for a second. And you're gonna take a breath in for 4 counts and a breath out for 4 counts, and you're gonna do that 5 times. And as you breathe in, pay attention right now to how your body feels. Are you cold in the room? Are you feeling hot? How does the chair feel against your body? Is it uncomfortable? Is it comfortable? How do your clothes feel against your skin right now? Are they tight? Are they loose against your skin? Pay attention to the noises that you hear in the room. Now take another deep breath in through your nose and out through your mouth, and slowly open your eyes. Now, that's like the 3-second version of the beginning of sensate therapy. Now you might think, oh, that's just mindfulness, that's meditation. But I'll tell you what you're gonna do when you go home now. When you go home, you're gonna take a hot shower, all right? Everyone can do this, by the way. I do it a lot. You're gonna go home, you're gonna take a hot shower, you're gonna get out of the shower, dry off. If you like, some of my clients really like using like the warm lotion because they don't like cold. I don't care. Rub lotion on your body, and you're doing this alone first. And you get underneath your top sheet. And then my clients say, I don't have one. Well, a light blanket. Just a light blanket, naked, right? And all you're gonna do is feel what the sheet feels against your skin. And the reason we do that is we're trying to understand what parts of your body are your erogenous zones. And this is a very clever way of figuring out what parts of your body have the most sensitive to you in nature. So you're gonna do that first, and then you're gonna your partner will do it. As we go through sensate exercises, we start to explore you on your partner's body for 15 minutes from head to toe. Not a massage. I've had clients say we took out a massage table. No. This is not like you're going to a massage. This is a sensual massage from head to toe, 20 minutes. And I know people roll their eyes when I say 20 minutes on one person. 20 minutes on my partner, I don't wanna do that. You're gonna do it because you're figuring out ways that you're arousing the other person's body with the focus away from the genital area. That's first, right? Because think of it as kind of like a foreplay technique, right? How to arouse your partner when the pressure and the focus, and I'm not just thinking about, am I gonna get erect, we were used to that thought already right now. Now we're thinking, how can I start to feel pleasure and how can I start to feel arousal in other areas? And lo and behold, what happens, we start to see that the erection starts to come when I'm not worrying all the time, is it gonna come, is it gonna come, is it gonna come? So by me taking it off the table and saying, I know you wanna go there, but we're not going there right now, you start to feel your body unwind. And again, we put in these mindfulness exercises at the same time. Now, I know this might seem like hocus pocus to a lot of you, and honestly, like some bullshit, I get it, but at the same time, I've done it plenty of times to know that it works. And if something doesn't work, I'll give you another exercise to try, another sensate exercise. The reason it's called sensate is because we're working with sensations. So next step, we're bringing in hot and cold temperatures. Again, it's fun, right? We're trying to figure out where your body feels the sensations. Well, I'll ask you, and honestly, I can give you some sites to get them from because there's these ice cubes that are amazing, not drip ones, not the ones that go into your freezer because then No one likes that. So like now there's this company that makes these cubes that just freeze, but they don't drip. And so we'll experiment with that. And then we'll experiment with hot oil, not boiling oil. Because I've had that happen. I've had all the mistakes that you could probably ask me about, we've had. So it's like hot wax that you can get, and again, you're like practicing on your partner's body. A lot of times we'll use a blindfold, because again, that heightens the sensations. So what we're really trying to bring back again is this arousal, this desire, this lust, the passion. And again, the focus is away from the penis, because if you're focusing, what is my penis doing? Is my penis getting erect? What's happening now with my penis? Is it working? Is it hard? Is it hard now? You know, that's when you start to go crazy. And again, it doesn't work that way. So we start from scratch, again, with the focus away from the penis. Just want to make sure I have so many notes.